Hello, my name is Kayla Christie. I am a master's student in the Ohio State University College of Social Work, and my evaluation project was based on brief cognitive behavioral therapy for the treatment of mild to moderate severity major depressive disorder. I completed my evaluation and field practicum at Allwell Behavioral Health Services in Noble County. Allwell is a community mental health agency that serves 6 counties in East and Southeast Ohio. Allwell provides services such as individual therapy, case management, workforce development, psychiatric medication services, consultation and prevention services, group therapy, and peer recovery support services. Individuals selected and involved in this evaluation were 2 women between 18 and 29 years old. They were selected at their intake biopsychosocial assessment based on a mild to moderate major depressive disorder. Client 1 was a 22-year-old Caucasian female presenting with loss of motivation, feeling depressed, sleep difficulties, a loss of energy, low self esteem, and concentration difficulties. Client 2 was a 19-year-old Caucasian female presenting with loss of motivation, feeling depressed, sleep difficulties, loss of energy, feeling like a failure, concentration difficulties, and feeling sluggish. The prevalence of major depressive disorder in the US is 7% annually, and the prevalence is higher in women and persons between the ages of 18 and 29 years old. The desired outcome of this evaluation is for the individual's depressive symptoms to decrease in score, and also by observation. This evaluation served to answer 3 questions. Number 1, is brief cognitive behavioral therapy effective in treating mild to moderate major depressive disorder? Number 2, how will this information be helpful and useful for Allwell Behavioral Health Services? And number 3, should I use brief cognitive behavioral therapy in my own future practice? Brief cognitive behavioral therapy was conducted over 6 weekly sessions as a briefer, more condensed version of cognitive behavioral therapy. Individuals were given an orientation of the intervention, they set treatment goals, identified automatic negative thoughts and beliefs, challenged those thoughts and beliefs, and learned problem solving and relaxation skills. Cognitive behavioral therapy is one of the 7 modalities recommended by the American Psychological Association for the treatment of major depressive disorder and is one of the more popular research modalities for the treatment of major depressive disorder. In 2022, Worson et al. Conducted a systematic review of 37 different studies about the efficacy of cognitive behavioral therapy and found that the efficacy was consistent with previous studies. Here's the logic model for this evaluation and intervention. The inputs is that Allwell has a fully funded outpatient program, the staff to provide the intervention, and the office space to conduct therapy sessions. The activities, what we did, as previously mentioned, cognitive behavioral therapy is a current evidence-based intervention, and brief cognitive behavioral therapy is a condensed version of that intervention that was utilized in this evaluation. Some short-term goals or outcomes were to hopefully alleviate depressive symptoms in the participants, and that participants would learn 3 to 5 skills to manage their depressive symptoms if they were to return. Changes that would hopefully occur after the short-term outcomes was that participants would be able to identify and challenge negative thoughts and beliefs as they arise, and some long-term meaningful changes in the condition or status of those clients' lives would be that there would be a reduction in relapse of the depressive episode in the participants that were in this evaluation. The assumptions are that the client is willing to invest 6 weeks into therapy, that the outpatient program is already funded, that clients are willing to do homework between sessions, and that clients are willing to change. Some external factors include co-occurring disorders like generalized anxiety disorders and substance use disorders, and then also the stigma surrounding mental health in the United States and community in which the agency is. This evaluation is a single case design, specifically an A-B design that can help to determine if the individuals had improved symptoms during the intervention after a baseline measurement. There were at least 4 threats to validity that I could find. First is concurrent history. If an external factor is causing symptoms of depression in clients, such as the loss of a job, but is corrected by getting another job, the depressive symptoms could naturally lessen. and there's nothing that I can do as a clinician to stop those external forces from occurring. Number 2 is testing and instrumentations. Clients could answer the questionnaires with what they feel are the right answers rather than being truthful. I encouraged the individuals to answer truthfully and stated that there were no right answers when they were filling these out. The third one is statistical regression. If someone is not at a stable baseline, they're likely to regress back toward the mean or get better over time without intervention. However, there was no clinical way of obtaining whether there was a stable baseline for these clients. The fourth potential threat to internal validity was multi-intervention interference. Clients could participate in additional services like prescription medications and self-help activities and get better. I had asked the individuals during the biopsychosocial assessment if they were engaging in any of these types of interventions, and they had both stated no. The outcomes being measured were the depressive symptoms of 2 females between the ages of 18 and 29 years old. The PHQ-9, otherwise known as the Patient Health Questionnaire, is a 9-question scale for symptoms that can help to measure the severity of depression. According to Kronk et al., the reliability on this scoring is excellent. The Beck Depression Inventory Second Edition scale is a 21-question symptom scale that was created by Beck et al. And has demonstrated reliability and validity. Data was collected by me at intake, which was a biopsychosocial diagnostic assessment and was the baseline measurement. Then intervention data was gathered by me again at the 2nd, 4th, and 6th sessions. Data collection took at least 5 minutes during each session, which shortened the actual intervention time to around 40 minutes, give or take. And that was definitely an issue that I had not seen coming. I figured it would be kind of like a quicker, easier way to get data was to have them come into the session and do it there. But instead, it ended up taking up time that we could have been engaging in the intervention. The data was analyzed by the interocular trauma test by examining the line graphs exhibiting 2 client scores on the PHQ-9 and the Beck Depression Inventory Scale. It was also analyzed by finding the mean between phases of the evaluation, by visually examining the slope, and finding the percentage of data exceeding the median. Here you see client 1's Beck Depression Inventory Scale scores. Also, you see this green line across the graph at 13, at the score of 13, and that just represents the threshold of symptoms. So the client's baseline score was a 15. At the 2nd session of the intervention, she scored an 11. At the 4th session, she scored a 7. And at the 6th session, she scored a 4. You can clearly see a decrease in the score and therefore symptoms the client experienced through the intervention phase. The slope is also steep, indicating quick progress. Here again, we see client 1, but this time it's her PHQ-9 and her scores for that. So her baseline score was an 8, and here you see the threshold score, which is a 5. At the 2nd session, she scored a 6. The 4th session, she scored a 3. In the 6th session, she scored a 1. You can clearly see a decrease in symptoms in the score and depressive symptoms that she experienced during the intervention phase, and the slope is steep, indicating quick progress again. Here, we see client 2's Beck Depression Inventory Scale scores. Once again, seeing that score of 13 as a threshold for symptoms. The client's original baseline score was a 15. At the 2nd session, she scored a 14. At the 4th session, she scored a 7. And at the 6th session, she scored a 4. There's clearly a decrease in scores and therefore symptoms that she experienced during the intervention phase. The slope is steep, indicating quick progress. And here again, we see client 2 and her PHQ-9 scores. Here again, the score of 5 is the threshold for symptoms. The client originally, for her baseline, had scored a 9 on the PHQ-9. At her 2nd session, she scored an 8. At the 4th session, she scored a 5. And at the 6th session, she scored a 3. There's clearly a decrease in symptoms that she experienced during the intervention phase, and the slope is steep, indicating quick progress. Here we see the mean between phases for each client and their respective scales and scores. Both clients' mean scores dropped between phases, showing improvement with the introduction of the intervention. And here we see the percentage of data exceeding the median for both clients and for both their scores. The percentage of data exceeding the median on both scales for each client was a 1, indicating that treatment was highly effective. Overall, brief cognitive behavioral therapy proved to be highly effective for the 2 clients in this evaluation. The implications for this evaluation is that I will use brief cognitive behavioral therapy more often in applicable cases, and brief cognitive behavioral therapy is a way to offer episodic treatment to those who can't commit to the typical 8 to 20 sessions that cognitive behavioral therapy usually encompasses. This also means that brief cognitive behavioral therapy could increase successful discharges in the agency that I'm completing my fieldwork at, as typically people will self-terminate after a few sessions feeling as though they're better, even though they haven't completed the intervention. This brief cognitive behavioral therapy intervention, though, is shorter and can increase the outcomes that we are hoping to see in discharges. There were some limitations, though. There were only 2 clients involved in this evaluation with diagnoses of mild major depressive disorder, and there were no clients involved that had a diagnosis of moderate major depressive disorder. Multiple baselines weren't possible to gather due to the setting of the evaluation. In the community mental health service agency that I am working at, they don't have a set of time that we can gather baseline. Instead, it's complete the biopsychosocial assessment and get them set up for their first treatment session. Some lesson learned: if I were to do another evaluation, I would gather at least 2 data points for the baseline phase and include a participant with moderate major depressive disorder to evaluate efficacy. And I would also have some more data points in between so that we can really see the difference a little bit clearer, rather than just having 3 data points to judge it from. Here's a list of the references that were mentioned in the slideshow. Thank you for listening.